Thank you, everybody. I really appreciate you letting me come here. Thank you, Debbie, and to the Dawson family in Brookwood for setting this all up. We got a number of things we're going to talk about, and we'll do some interactive questions and answers at the end. And we'll go through a wide array of causes for GERD. It's not just one simple thing. GERD, first of all, stands for gastroesophageal reflux disease. And that's easier to say GERD than the whole thing every time. But there's a number of things that mimic it. It's not always GERD. Let's not forget about all the other things that can cause symptoms in your chest and upper abdomen. And there's a lot of different therapies for it. It's not just go to your local pharmacy and get some Prilosec. There's a lot of different things that can be done lifestyle-wise, dietary-wise, medicine-wise, and now surgically and endoscopically. So we'll go through some of the newest and current ways we evaluate it and treat it. We'll also do, at the end of the program, go over one of the major complications of GERD, something called Barrett's esophagus. That is kind of a pre-malignant condition for esophageal cancer. Esophageal cancers, all cancers are obviously terrible, but it's a very tough one to treat, and we do think it is preventable as long as we find the right patients to treat, and we'll go a little bit into detail on that, because that's one of the things we'd love to wipe out as much as possible. All right, so does everyone have GERD? No, not everyone has GERD. Everyone definitely has reflux every now and then, but that does not mean if you get heartburn here and there that you have GERD. GERD is a chronic disease. It's got kind of a vague definition, unfortunately. It's not a clear definition like, yes, you have heart disease, no, you don't have coronary artery disease. It's a variety of things that add up to the syndrome. Now, GERD stands for stuff refluxing or coming up from the stomach into the chest. So if you have 2 or more episodes of some sort of reflux or heartburn or indigestion, sometimes it's called, per week, and it happens over a chronic period, that's our loose definition of GERD. And that's, there's very mild forms of it, and there's really debilitating forms of it. And it can really wake you up at night, alter what you eat, can cause cancer, can cause strictures, which is narrowing and scarring of your esophagus. And I've seen a lot of people in the middle of the night, believe me, far too many actually, they come in with some piece of meat or bread stuck in their esophagus that we have to pull out in the middle of the night, unfortunately. And we love to prevent that, both for you guys and obviously, it's a terrible thing to go through. How many people have GERD? It's an estimate. There's a lot of population studies that go on throughout the world. In the U.S., we estimate somewhere between about 15 to 20% of people really meet the definition of GERD, the vague definition we have. Is everyone being treated for GERD? No. Lots of people will not go for evaluation because a lot of people grow up with it and don't ever address it because they think it's part of normal life. But we have to be careful. Again, it is the primary cause of esophageal cancer in this country and complications from it, so we do not want to ignore it. I have a couple of pictures up here. Hopefully they display okay, to kind of get an idea of what GERD can do and how we start to classify it. So GERD can cause problems with your esophagus and symptoms in your esophagus. And what does it cause? It can cause irritation. It feels like burning or hurts when you swallow. That can be manifested when we do an endoscopy with little linear ulcers or breakdown of the lining of the esophagus. This basically is the esophagus, and as we go down through the esophagus, we get into the stomach. So we call this the gastroesophageal junction. There's a muscle, a round circular muscle, which we call a sphincter, the lower esophageal sphincter, which controls what goes in and out. And the ideal is it only opens up when you're trying to eat, and it closes up otherwise. It keeps things down in your stomach. Unfortunately, the lower esophageal sphincter doesn't always follow the rules, and it relaxes too much, and you get reflux of gastric material. That can be food, different gastric juices, which includes acid and something called pepsin, and a variety of other things. Even bile. Bile can be a terrible irritant to the esophagus. So this is what we'll call erosive esophagitis, or erosions or breakdown of the lining of the esophagus from reflux. It can get much worse. This is a mild case. You get much worse where we see over here, and we see the opening where it should be nice and big, become very small, and that's called scarring or a stricture of the esophagus. And this is what will cause trouble swallowing, and that's a common complication of reflux that we see. This can be treated by stretching or dilating esophagus. It's a pretty common thing we do when reflux is undertreated and people get this type of situation where they get significant scarring. This picture down here, it shows some little breaks. You can see a little break in the lining here, a little one here. But the big abnormality on this picture and a common complication is instead of a nice round, line here which separates the esophagus, which is this light pink stuff, to the stomach, which is this darker salmon color. The esophagus tries to protect itself from all this acid and irritation. So the stomach has no problem handling acid. The esophagus was never meant to handle that exposure to acid. So it starts to change from esophageal lining to stomach lining in the esophagus. So during that change, we can see stomach tissue creeping up essentially into the esophagus because of this natural response our body has, trying to protect itself. And that's what we call Barrett's esophagus. And it calls in all shapes and sizes and how it looks, and I'll go over that at the end of the talk. Unfortunately, this is what we look for when we screen people for Barrett's esophagus and pre-malignant conditions. This is the precursor to esophageal cancer, kind of like you do colonoscopies and looking for colon polyps, treating it before it ever becomes cancerous. And we take biopsies and we look for any early changes. And if we see early changes of cancer, we call that dysplasia, and we treat it aggressively, trying to eliminate all this irregular tissue. We can cut it out endoscopically, or we can burn it endoscopically. There's multiple ways that we can treat that. And this is the most common lesion we see before esophageal cancer. The next picture over, you can see the esophagus and stomach, and then this growth, this very irregular, nodular, angry-looking area. This is an early esophageal cancer. And you can still swallow food. You may feel some irritation, but it doesn't cause a lot of symptoms different from reflux until it becomes a large tumor or is growing and spreading, when it becomes almost impossible to treat well. So the goal is to catch things early and treat it and try to prevent things as much as possible. All right, so GERD not only causes esophageal problems, it causes things outside the esophagus and GI tract as well. A lot of people have hoarse voice, throat, soreness in the back of their throat. A lot of people who have, I don't think it doesn't cause asthma, it's never proven to, but it can certainly make asthma difficult to treat and keep under control. Especially if you have a lot of reflux at night when you're laying flat, you can actually get aspiration of reflux into your lungs, and it can cause this chronic worsening of asthma. So anyone that's not responding to their regular asthma therapy, we should be evaluated for it. 3 common causes of chronic cough are asthma, postnasal drip, which people get a lot with seasonal allergies, and reflux. Reflux is a common cause of a chronic dry cough, and you're trying to figure out what's going on, don't forget about reflux. And one of the funny things about reflux is you think if it causes all these problems, everyone would know right away if they have it, but there's lots of patients with silent reflux, meaning reflux occurs, but you really don't have much symptoms outside of hoarseness or dry cough or some of the other things we see with GERD. Let's see. Yeah, keep going. All right. A lot of people have terrible chest pain. They come to the ER. We see that all the time. And during my training, I worked with a cardiologist who was fantastic. His name was Sanjeev Patel, up in New Jersey where I trained. And he would always say, I love the mail-ox moment as a cardiologist. When people come in, they think they're having this crushing, burning chest pain, and they think they're having a heart attack. And you certainly have to be evaluated for that with the appropriate risk factors. Hypertensive, diabetic, family history, and you're certainly someone at risk for coronary artery disease. Certainly you don't ignore that, but more often than not, I think a lot of the chest pain that comes into the ER is terrible reflux, and probably because bad reflux will actually cause spasm of your esophagus and can really mimic angina or cardiac type chest pain. So, and obviously when you come in with that, you're going to get EKGs and lab work and all sorts of workup, and probably see a cardiologist in the process, possibly a stress test. But if all that comes back negative, most common thing causing non-cardiac chest pain will be reflux and GERD. So, and that's when we get involved. But yeah, one of my attendings when I trained, when it sounded really GI sounding and not cardiac, he'd make sure to get a large amount of Maalox and see how that chest pain does. And if it resolved, we call that the Maalox moment. Now, if a cardiac workup is negative, kind of like I explained, we'll do a whole GI workup. That may include a pH study to see how much acid is being refluxed, may require an endoscopy, or maybe if you're young and don't have many risk factors, we may just start an acid reducer. We call that PPIs, proton pump inhibitors. There's a variety of acid reducers. This is the most commonly used one. This is in the same class as what you commonly hear, like Prilosec and Prevacid and Nexium, and there's about 6 or 7 of them now that's available. Some over the counter, some prescription. Well, the one step down, which is commonly used as well, is something called the H2 blockers, and those are your Zantacs and Pepsids and Tagamets and things of that nature, which is also commonly available over the counter and prescription. All right, and we talked about another common complication of GERD is a chronic cough. So someone has a chronic dry cough and it doesn't seem to be related to certain blood pressure pills or asthma or postnasal drip and allergies. GERD is something we always look for. All right, so esophagitis is one of the complications of GERD. It just means anytime you see itis, it means inflammation of something. So inflammation of the esophagus is what we call esophagitis. And it can be very mild to very severe with ulcers and strictures and Barrett's esophagus, like we talked about a little earlier. So what increases your chance of having this acid reflux or heartburn cause esophagitis, where you have significant inflammation, not just symptoms of heartburn, but actually damage to the lining of the esophagus? Hiatal hernia is a term everyone's probably heard of. It's a very common finding we see. It does not mean it's going to cause esophagitis. It does not mean it causes your GERD. It generally will not cause any problems whatsoever. A hiatal hernia is a little bit of your stomach coming up into your chest cavity above the diaphragm. The diaphragm is the muscle that separates the chest cavity from the abdomen. And we probably see that between 30 and 50% of patients. It's a very common finding. And they're generally small, and those don't really cause problems. When they're very large, I've seen people with half their stomach in their chest. It can become extremely debilitating and symptomatic, where things are unable to pass to the abdominal area of the stomach and just chronically refluxes. And that's a very extreme case, but somewhere in the middle, you start to get symptoms from hiatal hernias. Generally, the large majority have small hiatal hernias and really don't do much damage. But the larger ones we'll see with that severe inflammation of the esophagus. The second one here, LES hypotension. That stands for lower esophageal sphincter, that round muscle that controls the emptying of the esophagus into the stomach and vice versa. That's the most common cause, far and away, of reflux, of gastric contents into the stomach or GERD. And if a muscle is relaxing excessively, it's hard to treat that with just medicines. And we can measure how that muscle works with something called manometry. This is a test we do at Brookwood and a variety of other places. But they have a great setup there. We have a well-trained staff that we do this frequently on. We actually place a little nasal cannula down the nose. It's not a fun test, but it's short and gives us a lot of good information about how your anatomy is working without having to do an invasive procedure like an endoscopy that requires sedation. And we can measure, as you drink some water, with this catheter down your esophagus and your stomach, how the muscles are all working. You should have good peristalsis. That means the muscle squeezes up top when you eat something or drink something, and kind of like a snake will squeeze down, pushing it down your esophagus. And then once you get to the bottom, the sphincter, round muscle, needs to relax and empty your food into your stomach. And once you're done, it needs to close right back up. If it doesn't close, that's when we see a lot of reflux. And this may happen after eating. It may just stay open for a while. So some people get reflux after eating right away. And some people may just relax excessively at random times, not even with swallowing. And that's when you get a lot of nighttime symptoms and symptoms even without eating. And those are usually the more severe cases. Loss of peristaltic function, that's kind of like that coordinated muscular movement of the esophagus. Obesity, and particularly abdominal obesity, when we see a lot of central fat. There's different types of fat distribution for everyone. But there's some people that really concentrate fat within the abdominal cavity, not on the outside, but the inside of the abdominal cavity, around your organs. And that can really push on the stomach and cause increased pressure in the stomach, and a little bit easier then to reflux as it pushes on the stomach. That little esophageal sphincter is not that large of a muscle and not that strong. So as soon as you start pushing up against it, it'll relax and allow things to reflux. So obesity and getting your weight down under a BMI of ideally 25, but I generally recommend under 30 if you're obese to get it down below that. And that should help significantly. And the goal is, not to keep throwing medications and surgeries at things, but really change our lifestyle to help prevent symptoms. There's certain tumors. Sometimes we treat people very aggressively and we can just not get them better. So we look for other causes of excessive acid release in the stomach. And there's actually a tumor called the gastronoma. The gastronoma is a tumor usually actually in the pancreas that releases a hormone that causes your stomach to constantly release acid. And it can cause severe ulcers, severe reflux, and it actually has a name. It's called Zollinger-Ellison syndrome. It's not common, but I've seen a few cases, and it's some of the cases where we just can't figure out why people don't respond to pretty aggressive therapy. That's something we go looking for. And that can be done with endoscopy of the pancreas, ultrasound, and different imaging techniques and different lab work as well. Delayed gastric emptying, I don't know if anyone's heard of that. Sometimes it's called gastroparesis. There's a variety of diseases that causes your stomach not to empty well. So esophagus works fine, but once the food gets to your stomach, it just sits there for hours and hours and hours. Stomach should really empty within 2 hours, the large majority of your stomach. Some people's stomach, because of certain diseases, can cause it to empty over 8 hours, 12 hours, sometimes longer. So if you're having a lot of fullness after eating and bloating and you just can't feel like you can finish a normal meal anymore, that's usually because of delayed gastric emptying. We see it in a lot of poorly controlled diabetics. We see it in people that have had some sort of surgery that damages the nerve that runs along the stomach. That's called the vagal nerve. So some people have had chest surgeries or chest trauma of some sort. That nerve will be injured and the stomach will become pseudo-paralyzed, will not empty well. When the stomach fills up real big, it'll cause pressure on that sphincter and you'll have reflux. So there are some ways. It's difficult to treat, but there are some things we can do to treat it. And the main thing is that we find out if you have it or not. Otherwise, you can take acid reducers all day and it won't help you. Gastric outlet obstruction. This is kind of like gastroparesis or delayed gastric emptying, except it's not because your stomach's not functioning. There's actually a blockage in your stomach. So sometimes ulcers or tumors where the stomach empties into the small intestine will cause your stomach to just fill up and have a very difficult time emptying, and that'll cause a lot of reflux type symptoms. And then overeating. That's usually episodic, but overeating regularly, unfortunately, is a common problem here, and it'll cause a lot of post-eating reflux. We get a lot of visits after Thanksgiving and Christmas. And it's just like, I just can't get better. This is a picture of the anatomy of the esophagus going to the stomach. So the esophagus is over here, and there's a thickened area. This kind of lighter color, that's depicting the muscle layer of the esophagus and the stomach. And it's all one continuous muscle, as you can see, but it should be nice and cinched shut. This is the diaphragm. That's the muscle that separates the chest from the stomach or abdomen. And everything should be going forward. We like everything going forward. When things go backwards, that's when it causes problems. Um, a weak muscle, that relaxes excessively, large majority of your stuff will go forward, but a lot of gastric juices and gastric contents, food, will reflux back up if this does not cinch down, like we see over here. All right, these are some. Then we have 2 classification symptoms. We won't get too detailed with this one, but when we do endoscopy, we're not just taking a look and just saying, all right, hey, you have this. We're trying to classify how severe it is. It will help direct how aggressive we should be with your therapy. So there's 2 classifications we use, and if you have a gastroenterologist, you can ask them what class of esophagitis or reflux causing or damage from reflux do I have, and it'll give you an idea of is it mild, is it severe, what should I plan for in the future, should I be rechecked in a couple of years, and it helps direct a lot of future care. And you can see, there's very mild looking stuff to terrible looking stuff like this. You don't even have to look at esophaguses, but that as soon as you see this, it looks terrible. And we're able to classify this into ulcers, strictures, tumors, Barrett's esophagus, and help classify how severe reflux is. And then we can follow you over time and see, is it getting better, is it getting worse? Do we have to be more aggressive and do anti-reflux surgery because medicine's just not working? So this is one classification. We call it the Savory-Miller. There's 4 classes. Lower the number, the milder it is. The higher number, the more severe. And we have another classification. This is the one I use, the LA classification. And we use A through D, A being mild and D being severe, with ulcers and involving the whole esophagus, not just little small breaks. And again, this is something your gastroenterologist can tell you based on endoscopy findings, how severe it is. All right, so people ask, can you just talk to me and figure out if I have the symptoms and just treat me? Most of the time, yeah, absolutely. You can figure out from a history, yeah, you have classic GERD symptoms. But again, we don't want to miss severe GERD that leads to complications. So we try to take a pretty detailed history. When we talk about GERD, we'll really try to we'll try to get you better first. And follow-up visits, we'll really get into the details of how severe your symptoms are, how's it affecting your lifestyle, how you sleep, etc. And certain things will, say, hey, we should actually take a look and see how much damage there is. There's certain worrisome alarm signs that we pick up on that necessitate further workup. And I'll get into those in a moment. The interesting thing is, I was telling you a little earlier, a lot of people have silent reflux. They may just have cough or chest pain, but they don't complain about heartburn. Everyone thinks heartburn is the only way you know if you have GERD, but it's not. They did a study in Northern Europe. It's amazing they were able to do this, but they signed up 1,000 random people to have endoscopies. And they wanted to see what their esophagus looks like and then compare it to their symptoms. So everyone got an upper endoscopy to evaluate what their esophagus looks like. 1.6% had what we call Barrett's esophagus, that pre-malignant condition. Only 40% of those patients had any symptoms of GERD or reflux. So the majority have this pre-malignant condition and do not have any symptoms. So it's a little scary. You can get advanced disease without even having much symptoms. 15 to 16% had inflammation, the esophagitis, but only a third were symptomatic. So again, people may just get used to it and they can't even tell anymore that it's not part of regular life. So we do try to take a pretty detailed history and even look for minor symptoms to say, all right, maybe we should treat you for a little while and see if you feel any different, better, or should we do an endoscopy to figure out. Again, endoscopy is invasive, you have sedation, we try not to overuse it, but it really is the best way to tell if there's inflammation of the esophageal lining. And then there's something called NERD, N-E-R-D. I was a nerd growing up. I'm proud of it, but NERD stands for non-erosive reflux disease. So these are people that have symptoms of GERD and reflux frequently, but don't have any damage. So really, you're having reflux, you get heartburn, but it's not severe enough to cause any damage to your esophagus. So we try to use milder therapy for that. About 2/3 of patients with reflux symptoms don't have any, like, if we do what's called a blinded study where you send people to me and tell me, go look for esophagitis changes. I'll take a look with an endoscopy at the esophagus, joining up with the stomach, and I'll tell you, all right, this person has reflux changes, this one doesn't, or esophagitis changes. But I wouldn't be able to predict it on 100% of people based on their symptoms. So sometimes you do have to do endoscopy to figure out for sure if you do have reflux changes and inflammation. All right, so I told you how we get people in the ER all the time with chest pain. There's a wide variety of things that cause chest pain, not just reflux and not just heart attacks. There's a lot of things that cause referred pains. The most common thing that everyone hears about is angina. Sometimes you get chest pain that actually refers to your neck and jaw or maybe down your arm. That's called referred pain. You're not having any problem with your arm, but you're having referred pain because of how your nerves are distributed around your body and how that feeds back to your brain. So infectious esophagitis is one thing. It's not because of reflux, but different infections can actually involve the esophagus. A common one is fungus or candida. I'm sure some of you have heard of that. Yeast. Sometimes people that use inhalers with steroids will get yeast down their esophagus and cause some pretty bad symptoms. Some people that have a compromised immune system, if they've had chemo or chronic steroids for something, it'll actually cause viral infections of your esophagus as well. Very rarely do we see bacterial infections of the esophagus. It's mostly viral or fungal. Pill esophagitis. That's sometimes a call we get in the middle of the night. You get a large pill that gets stuck in the esophagus and sits there for a while. If you don't do something about it or do something to get it down, it can actually cause an ulcer in the esophagus and cause this terrible inflammation and irritation with eating and just with a lot of daily activities if you don't get that treated aggressively. This is the big one. I've been diagnosing this a lot in my younger population. Something called eosinophilic esophagitis. Eosinophils are a type of white blood cell that you see with allergic reactions. So I don't know if you guys read about, but food allergies have really become more common and more diagnosed probably. People are looking for it more and more these days. So there's a group of foods that people have common allergies to: beef, soy, seafood, certain nuts that cause significant inflammation in your esophagus. So it's not just, oh, I got a swollen tongue, I got hives. It can cause symptoms and irritation of your esophagus without all the other symptoms. So you don't realize you have a food allergy until we take a look with an endoscopy. A lot of these patients present with similar symptoms to reflux and also a lot of trouble swallowing. Food gets stuck, they have to drink water to get it down, stand, walk around. That's never normal, so always ask about that with your primary care doctor or GI. Ulcers, sometimes ulcers in the stomach will actually cause chest pain. They can refer. Non-ulcer dyspepsia just means pain from the stomach that can refer up, but that's without ulcers. Biliary tract disease, that's referring to the gallbladder and the bile ducts that drain the gallbladder and liver. Sometimes gallbladder disease will cause terrible chest pain. That's a common place it refers to. Sometimes it will refer to your right shoulder and your right shoulder blade actually. Coronary artery disease, set up for a heart attack if you have bad coronary artery disease. That'll certainly cause chest pain. And then there's something called motor disorders. These are abnormal function of the esophagus, that peristalsis, that'll actually cause severe spasm of the esophagus, and it can be a terrible pain that's very difficult to break. There's certain muscle relaxers we can use to help relieve that. All right, this is the one we talked about a little bit earlier, eosinophilic esophagitis. That's that food allergy related inflammation of the esophagus. And what you see when we do an endoscopy, you can kind of see, it almost looks like there's little rings in the esophagus. We call that a feline esophagus or ringed esophagus. Sometimes you can get these little lines that go up and down and little white spots. Those are clusters of inflammatory cells, or like a little abscess or boil that you may see on your skin. We can see that happening on the esophageal lining. When we take a biopsy, the pathologist looks for certain characteristic findings of this food allergy. And there's certain cells in this slide they count up called eosinophils. And if you have a certain number, it's consistent with food allergy-induced esophagitis. And this is something we test for commonly on endoscopy when someone's not responding to typical therapy. A lot of patients have, at the same time, have asthma or atopic dermatitis. We see that kind of run in groups together. And the most common groups of foods that we see with this is milk, egg, wheat, soy, peanuts, tree nuts, seafood, and I would say beef as well. Those are the most common foods that we see people have allergies to. And sometimes, if we eliminate that food group from the equation, you can get off all meds and all symptoms resolve. And I've seen that quite often. All right, we talked about, we just talk in the office the first time, and we'll talk about lifestyle changes. Most people know what to do. They learn what foods to avoid, but there's a lot more to just avoiding certain foods. And I always tell my patients, it's not like you can never have this. You just got to have it in moderation. Be careful about it. The most common perpetrators for causing acid reflux is citrus, which has a lot of acid in it. Tomatoes have a lot of acid. Onions, carbonated beverages, spicy foods can cause a lot of inflammation and discomfort if you have reflux already. Caffeine is a big one. A lot of people have tea and soda and they're like, I don't drink coffee, but no, there's a lot of caffeine still in your diet, so you have to be careful about where you find caffeine. Chocolate has a lot of caffeine, so in moderation, totally fine. Mint is a big one people don't know about. I've had a few patients that tell me, I have a bag of mints every day, or I have mint gum all the time. Mint is a natural muscle relaxer. It's not strong, but again, this lower esophageal sphincter is a small muscle, and it's enough to cause it to relax excessively and cause reflux to worsen. So take the mint out of the diet. Smoking, terrible irritant. We talked about obesity, weight reduction. Our goal is to get BMIs under 30 for reflux, and ideally under 25 is the goal overall. Reduction in alcohol, not elimination, but reduced alcohol intake. It can be an irritant. When we have nighttime symptoms, people that wake up in the middle of the night with reflux type symptoms, we always try to tell people, make sure you're not eating 2 to 3 hours, really 3 hours before laying flat, whether it's for a nap or sleeping at night. And what really works well is elevation of the head of the bed. And not just, that doesn't mean get 3 pillows under your head. That's not what we're talking about. We're actually talking about tilting the whole bed. And that works much better. Some of these beds come so that you can kind of sleep in an inclined position. That's not it either. It's really trying to get your whole body and gravity to help with keeping things down in your stomach instead of coming up. So a 4 to 6 inch block under the head of the bed is really what we're talking about when we say that. Sometimes the excessive pillows and inclined beds will actually cause more pressure on your abdomen. So it's better to have your body straight and a little bit inclined. Smaller meals, more frequent. I always tell everyone does better with GI symptoms if they just have smaller meals. I don't care if you have 5 meals a day, just make them smaller size instead of large dinner, large lunch. That's just not how your stomach was meant to digest food. And then, again, obesity. There's some people, when they wear tight garments, will have worse reflux. Again, that's just increased abdominal pressure. It's kind of hard to predict who that will happen on. All right, so what medications can we try? We talked about one class, the PPIs, the proton pump inhibitors. That's the one in the news that has all these terrible side effects now being listed if you use it chronically. And we'll kind of go over these side effects and when we have to be careful and when we shouldn't be careful and when we should really use the medicine. Because again, remember, bad reflux can lead to strictures, cancers, so we have to weigh the risks and benefits of medication just like we do with everything else. These are the common ones we see in the pharmacy: Zantac, Pepcid, Tagamet. Those are your H2 blockers. Those are the older, milder acid reducers, but do work well for mild disease and tend to have less side effects than the proton pump inhibitors long term. So we do try to transition people to low doses of proton pump inhibitor. if they've been on it for a long time. Some people have been on this for decades before they ever see anyone about it. And your common proton pump inhibitors we talked about, Prilosec, Protonix, Nexium, Prevacid. These are names a lot of us recognize. And they come in all different dosing and efficacies, but they're all very similar. There's some newer ones that are not on this list here. Common side effects to both of these meds, the most common are headache and diarrhea. That's the most common side effect we hear complaints about. Sometimes some people have a hard time just tolerating acid reducers. They can actually cause pain to some people, particularly the proton pump inhibitor class. All right, and there's a lot of studies that have been done. Which is the best one to use, which type, how often. Some people take theirs twice a day. There's no good proof that twice a day helps ever. There's certain conditions where you have ulcers, or if you have severe inflammation with ulcers in the esophagus, that twice a day may be good for maybe 6 weeks, 8 weeks, but not forever. We're really trying to reduce how much medicine people are taking these days. Safety. So safety is a big question. We get patients that are new to me that have been on acid reducers for 20 years over the counter or from their primary care doc, and primary care docs are talking about it as well with a lot of their patients now. What are the potential side effects? Malabsorption. So acid, it's in your stomach for multiple reasons. It helps you break down things, helps prevent certain infections, and helps you absorb food. So if you eliminate all the acid in your stomach, or a majority of it, it will actually cause problems absorbing certain vital nutrients. Vitamin B12 deficiency we see a lot. That can cause fatigue, neurological syndromes. Iron deficiency we see, calcium deficiency, vitamin D. This is very big, particularly in postmenopausal women with osteoporosis. So long-term acid reducer use, we get worried about worsening of osteoporosis in women. Men too, but more so in women. And we see people that are on it chronically, we see more hip fractures on it. So not a large number more, 1.4 times more, but certainly an increase, so it is related. Infectious gastroenteritis, again, acid helps prevent certain infections in your GI tract, so people can be slightly more prone to GI infections. C. difficile. Have you guys heard of C. difficile? Is that something you guys heard of? It's a terrible GI infection, mainly in the colon, that causes terrible diarrhea, can cause colitis or inflammation of the colon. I've seen, unfortunately, a lot of people become septic and die from this. And it's a bacteria that's normally in your gut, but when you take a round of antibiotics, you may be treating sinusitis or some other infection, pneumonia. We see a lot in the hospital, unfortunately. It can kill a lot of your normal gut bacteria and allows this bacteria, C. difficile, to really overgrow. And it releases a pretty nasty toxin that causes inflammation of the colon. And then we have to do another round of antibiotics to treat it. So you have to be careful taking antibiotics for any reason, because you can, again, have complications. And unfortunately, with the acid reducers, you're even more prone to it. Reflux can be pretty bad in pregnancy. Generally, most of the acid reducers are safe. There's one in particular, Prilosec, which we do not recommend. That's the most common one we see over the counter. So we advise pregnant women with bad reflux to go towards the milder meds, the Zantac and the Pepsids. And then thrombocytopenia, that refers to low platelets. That's some of your clotting factor in your blood. And chronic use of proton pump inhibitors and H2 blockers will sometimes drop your platelet counts. So that's something we watch for. This is theoretical, but again, acid protects your stomach from a number of things, particularly something called H. pylori, Helicobacter pylori. It's a common bacteria that causes ulcers in the stomach. It's the most common cause of ulcers throughout the world. The second most common cause are anti-inflammatories like Aleve, Advil, Goody powders, things like that. But if you're going to be on chronic acid reducers and you're having a lot of symptoms, you always check for H. pylori and make sure that's not overgrowing. Normally the acid will help keep it somewhat suppressed in the stomach, and then there was a big controversy a couple of years ago I don't know if anyone's on Plavix or know people that's on Plavix. It's a common blood thinner used after someone gets a cardiac stent or stroke. And there was increase, they thought, what looked like on trends, an increase of heart attack or stent malfunction when you were on an acid reducer. That's been proven to be false, and it's safe to use Plavix and acid reducers, but 4 or 5 years ago, we used to try to change people off of it because it looked like there was some trend towards increased complications and the Plavix not working as well, drug interaction, but that has been proven false. And that's a common question we still get. Some of the newer concerns, the big one is dementia. It was mentioned a little earlier today for a future talk here. There's been some trends and links towards could there be earlier onset of dementia if you're prone to it if you're on a long-term acid reducer. There's been some recent articles, actually just last week, showing that that's not been proven true. They've been doing a lot of what we call retrospective studies of looking back at patients that have been on acid reducers for years and years and years, and there has not been a clear connection. It's still being studied, but we're not sure if that's true or not. And then chronic kidney disease, again, this may be due to different drug reactions or direct damage from the acid reducer to the kidneys. A lot of drugs are filtered through the kidney, so all drugs usually get eliminated by one of 4 ways: stool, urine, and kidney, kind of together, or metabolized by the liver. So a lot of the acid reducers need to be metabolized and eliminated through their kidney. So there are some links to chronic kidney disease if you are on this for too long. Again, being studied, not totally sure yet, but it's a trend we're looking at. Pregnancy, what can we use for, a lot of this common question, what can I use for reflux in pregnancy? There's a number of options that we talked about a little bit earlier, but always we start with dietary lifestyle changes. Antacids. Antacids are a common term used. It includes a lot of drugs that are more over-the-counter and immediately acting. They don't suppress acid production in the stomach. So that's your Tums and Maalox, Gaviscon, Mylanta, all good for kind of immediate relief. When you use these H2 blockers, PPIs, it takes a little while for them to start working. So if you need some immediate relief in the middle of the night, these are kind of your general go-tos. All right, so who does need an endoscopy? There's certain alarm signs we look for. Again, most can be managed in a general practitioner's office without much difficulty. But more severe cases, if you're having refractory symptoms or symptoms despite being on this strong acid reducer, yeah, we need to figure out why that's going on, look for all the other causes we talked about earlier. If you have chronic symptoms, even if it's well controlled, again, esophageal cancer is a terrible disease. It's increasing in incidence in the United States, unfortunately, more so in women than men. So if you have chronic reflux disease that you're required to be on acid reducers for a long time, we do talk about screening for Barrett's esophagus and changes. There's no guideline. It's not like a mammogram or a pap smear or colonoscopy where you hit this age and you should do this. It's more of a discussion between the patient and the doctor and deciding who's right and who doesn't need it. If you start losing weight unexpectedly, that's always a worrisome sign, and we'll evaluate. If you have bleeding, these are terms for bleeding, vomiting blood or black stool or some sort of ulcer type bleeding. When you have bleeding in the stomach or esophagus, it gets digested and turns black, and that'll cause black stool. If you have new iron deficiency on routine blood work, that's always a worry for some sort of GI bleeding, so that may be a clue to go looking for any GI problems. And then something called dysphagia or odynophagia. Dysphagia means trouble swallowing, food getting stuck, slow to go down, or odynophagia. It really hurts every time you swallow something, or if you have even fluid sometimes. All right. And what do we do in the GI office? A lot of people get referred for GERD. We'll do our history and physical, really examine you and get a sense of how severe your symptoms are, how frequent, how it's affecting your lifestyle. You know, if there's some symptoms of gallbladder disease that we think are causing your chest discomfort, we'll do an ultrasound, which can be very useful. Endoscopy or biopsies, we select out patients that seem appropriate. There's something called a Bravo study. This is a little chip we can actually implant in your esophagus at a time of an endoscopy, and we can measure over a 48-hour period how much acid reflux you're actually having. But just the acid component of it. You can have reflux of food-like material and regurgitation, but this specifically looks at the acid and gives us an idea of how severe it is. And then something called manometry. That's when we check the muscles and how they're working. All right, so we talked about meds, evaluating, trying to figure out who has it, how bad it is. If it's really terrible disease that's causing significant damage to your esophagus or terrible symptoms that meds just cannot control and dietary and lifestyle changes cannot control, when we talk about surgical options, the most common surgery is something called Nissen fundoplication. And what they do basically is they wrap part of the stomach. It's a little hard to see, but there's little sutures you see here. This is the esophagus, and the muscle is right here that connects from the esophagus to the stomach. That's just too loose. You get all this reflux. So what they'll do is actually wrap some of the upper portion of the stomach, which actually is kind of floppy, and wrap it around the esophagus and cinch it down, and kind of creating additional support for the sphincter. It can work really well in a lot of people. It can have potential side effects, so we really try to avoid surgery until the last resort. Sometimes it has to be revised. Sometimes it's too tight and actually causes trouble swallowing, and sometimes it has to be loosened. It's not common, but we can see it. Some reports say up to 6%. Once you get one of these things, if you feel like you have a lot of gas in the stomach or you need to vomit, it's very hard to, because it makes it quite cinched down. So you can have this terrible feeling of needing to belch, but you're not going to be able to most of the time. And that can be a little unnerving to a lot of people. There's the nerve that runs up and down the esophagus. That's that vagal nerve we referred to a little earlier. If that gets damaged, then you can have very poor gastric emptying. You're operating right in the area where that nerve runs. Great care is, utilized to avoid that, but sometimes it's unavoidable. A lot of people do great for years and years, and this will loosen up over time, and eventually 60% of patients get back on medication. Usually right after this type of surgery, we tell people stop all your acid reducers, just stop them all. Usually people do pretty well. All right, there's a newer surgery available now. There's some long-term data coming out finally. It's something called the LINX, L-I-N-X. And it's named because you have links of these little magnets in a beaded bracelet, essentially. And this is actually a bracelet of magnets that will open and close based on a food bolus or a collection of food coming down the esophagus. The magnets are not strong enough, so they'll stay cinched, but enough to allow food to pass and then close right back up. This is placed right at the little sphincter. This is the esophagus, stomach here. And then these magnets get placed right around that junction. Just give it some extra support. This can be done laparoscopically, meaning just with the scopes, not with big incisions, and can do pretty well. The most common complication we see sometimes is, again, it might be too tight and you have trouble swallowing, but generally people tolerate that really well. It's more frequently being used. Unfortunately, insurance coverage, it varies state by state, and it's not a well-covered procedure, unfortunately, for most patients. But we expect it to change as more long-term data comes out. There's some newer modalities and surgical therapies available, and endoscopic therapies now, which is the trend of all types of surgeries trying to become minimally invasive. So if you can avoid incisions and scopes and do everything from the inside with the endoscope, that's our eventual goal. Sometimes you hear about gastric bypass for obesity. Sometimes people with severe morbid obesity, BMIs above 50, the reflux is just difficult to control. Those wraps are not very useful, and sometimes doing a gastric bypass is the best option to get people's weight down and control the reflux. So that's something that will be recommended as opposed to one of these wraps in people that are BMIs above 50, body mass index. This is kind of where I come into play a little bit. We're hoping to bring some of these technologies here. They're pretty new and emerging, so there's more research being done. There's some academic centers around the southeast that are able to do these procedures, part of trials and such. What's my imaging? There's something called a stretta. Stretta is a way of, you can see in this picture here, here's your esophagus, your stomach, and that sphincter right here. It actually you put little needles into the muscle, you'll burn the muscle some, stimulate it, and it actually grows thicker and stronger by doing that. And you can grow or kind of use therapy to strengthen that muscle without having to do a surgical procedure, all endoscopic. So that's something we're trying to get here. It's being done at UAB right now in select patients as we're kind of figuring out how effective and who best it's on. And then there's something called the TIF, T-I-F, which stands for transoral incisionless fundoplication. So it all sounds great. It's through the mouth, there's no cutting. Incisionless, there's no incisions at all. And then fundoplication refers to that tightening of the sphincter. So actually, what's an endoscope and a device is passed down the esophagus. And the area that we try to wrap tight, we can actually suture shut now, or staple shut with this device, trying to recreate that fundoplication tightening that used to be done surgically for decades now, but try to make it so we can do it endoscopically without any incisions. You know, it's a few centers are doing this, and we're just referring one out to South Carolina to get one done. And I think this is, between these two, you'll see this emerging over the next 5 to 10 years, and hopefully replace a lot of surgeries. And ideally, when you do these things, you want to get people off these chronic meds as well. Prior to surgery, again, the main goal is to make sure we're doing the right surgery, make sure that reflux is really what's causing your symptoms. We want to make sure that we evaluate you for all the other things that can cause chest pain and reflux-like symptoms. Doing surgery and then having no benefit is obviously a terrible thing. So we try to select out the patients that will benefit the most. I'm just going to spend a few minutes on something called Barrett's esophagus. This is what I specialize in and really enjoy helping patients with, because I've seen enough esophageal cancer. It's a terrible disease that's very difficult to treat, even with the best of options available. It's very difficult to treat. And Barrett's esophagus is that change of the lining of the esophagus. That's kind of our warning sign, like, all right, this is pretty bad and it's getting worse and we need to address it. This is, again, a little hard to see, but you see a nice line here, nice round line. That's your esophagus, that's your stomach, and going down, looking through an endoscope. And that's a very normal looking, what we call a Z line, or the junction between the esophagus and stomach. We saw a picture a little earlier when it starts to get very irregular, and that's what we call Barrett's esophagus, where the stomach tissue creeps up into your esophagus, trying to protect itself. And unfortunately, as this tissue grows, it starts dividing excessively and growing so many abnormal cells that it can become cancerous. And then this is what a tumor looks like in the esophagus. This involves about half the circumference of the esophagus and can cause bleeding, pain, trouble swallowing. But again, as it grows, when it's small, it doesn't cause any problems until it really gets big and causes problems. So what's the big deal? Obviously, cancer of the esophagus is bad. I've said that plenty of times. It has a very poor long-term survival. 5-year survival on all esophageal adenocarcinoma is 15 to 20%, which is abysmal. So we really want to prevent it or catch it early. It's increasing in frequency that we're finding it. We had about 16 to 17,000 new cases diagnosed last year in the United States. There's 2 types of esophageal cancer. The one at the junction where the esophagus joins the stomach is called adenocarcinoma. And the ones higher up in the esophagus, not at the junction, are called squamous. Usually they're squamous carcinomas. Squamous carcinomas are, you see more often in heavy smokers. If you have Barrett's esophagus, the risk for getting esophageal cancer is 30 to 40 times the general population, people that don't have Barrett's esophagus. We don't have a good strategy to decrease this incidence, these 16, 17,000 new cases every year. So we're being more aggressive with screening. That's been our best approach, and trying to catch Barrett's esophagus early and treat that aggressively before it ever gets a chance to become cancerous. All right, what are risk factors for getting Barrett's esophagus? Obesity is certainly a risk factor. More often, we see it in Caucasians, more often in males. We see it usually more in the middle-aged years, 50s. You have the symptoms of reflux or GERD. They're usually chronic and they're usually severe. And people with larger hiatal hernias can tend to get this more often. Again, tobacco, that certainly seems to be a risk factor. It's being studied more and more to see how much of a risk factor. And then nocturnal symptoms. People that have nighttime symptoms are more prone to developing this. Screening for Barrett's, it's controversial right now. There's no guideline like a colonoscopy or mammogram. So it's a discussion between patient and doctor, and picking out the right patients and making sure you're comfortable with it. We talked about some of those alarm signs. We definitely recommend endoscopy in patients with trouble swallowing or anemia. And while it's invasive, it's actually quite a safe test. Can usually be completed in under 10 minutes. The neurosedation we use with the help of anesthesia teams are really short acting and don't have some of the complications that we've seen in the past with the sedation. All right. How do we diagnose Barrett's? By looking and seeing and then taking biopsies of the area, and there's certain changes we look for. Metaplasia means you have Barrett's changes. Dysplasia means you have starting to develop cancer cells in that Barrett's esophagus. So we don't just call it Barrett's. Again, like I said, it comes in different shapes and sizes and types. We try to classify how aggressive it is. So dysplasia means you got cancer cells there, and we need to take care of them before they grow into a large tumor. Sometimes we get what's called nodular Barrett's, where you kind of see in this picture here, you get growth of abnormal cells. And while that's not cancer, that's much more prone to becoming cancer in the next few years. So we try to resect any nodules that we see that's associated with Barrett's. We classify how long the Barrett's is. So we look at where the stomach joins the esophagus. Actually, it's over here. This is a little hiatal hernia. This is a little bit of the stomach coming up into the chest cavity. This is the diaphragm, the muscle separating the chest from the abdomen. And then we classify, we actually count how many centimeters this length of abnormal tissue is. And then over here is this normal tissue. And if it's under 2 centimeters, the risk of cancer formation over a lifetime is much lower. Over 3 centimeters is the people we classify as higher risk. Surveillance. After we diagnose someone with Barrett's esophagus, we recheck the area. We get you on therapy, strong acid reducers, and recheck the area in a year and make sure there's no early cancer cells that are forming. And if it looks like it's staying stable, disease is well controlled, recheck the Barrett's esophagus every 3 years after that. If you have low-grade dysplasia, we used to then check every 6 months, and if it starts progressing and getting more cancer cells, then we used to send you to surgery. This has changed significantly. We used to send a lot of people with these early cancer cells to surgery endoscopically now, and this is what I do a lot of, is we remove these cells and areas of Barrett's without having to do surgery. Removing part of your esophagus usually involves removing that sphincter muscle, and it's a very difficult surgery. It's dangerous in the best of hands. When a surgeon doesn't want to do a surgery, that means it's dangerous. And most surgeons don't like doing these surgeries unless it's going to be life-saving. It certainly will be life-altering, but if it's a life-saving procedure, we'll certainly discuss it. But what's really become mainstream, or not mainstream, but available across the country. We did it over at Brookwood. It's something called Halo and EMR. And these are ways to eliminate all these superficial cancer cells without doing surgery like we used to send everyone for. Halo is something I do frequently. It's a burning of the superficial layer of the esophagus. And it can be a little painful, but it certainly beats a nasty esophageal surgery. And we'll burn about 3 millimeters. The esophagus is not that thick, but we'll burn about 2 to 3 millimeters of the lining of the esophagus and eliminate all those abnormal cells that are forming in your lower esophagus. And that'll re-go back into normal tissue. Very rarely will it become Barrett's esophagus again, as long as we control the reflux. And that's been a great tool that we've had. Very safe. Again, it's a little bit uncomfortable for a few days after the procedure, but much better than a surgery. EMR stands for endoscopic mucosal resection. And this is where we actually, like we remove a polyp in the colon, we actually remove all this abnormal tissue. We snare it off or cut it off. This is offered most places nowadays. There's additional training. It's called an advanced endoscopy year, like I did myself. And so usually, you have these large groups, but usually people that do this very often I've been trained in it in fellowship. There's something called endoscopic ultrasound. What we hate to do is something called burying disease. If you have a little nodule, just imagine a round nodule in your esophagus. If you just cut off or burn the top half and you ignore the bottom half, kind of a tip of the iceberg thing, that would be a great disservice to the patient, because it would look great on the inside looking at it. We took care of all this abnormal tissue, but if you leave abnormal cells buried in the esophagus, that will continue to grow. You won't be able to check it or see it until it causes a major problem. So ultrasound, when we look at the esophagus from the inside, we can actually look at the full thickness of your esophagus, and I'll show you some pictures, and make sure that we're doing the right thing for you. This is what endoscopic ultrasound looks like. So this is the layers of the esophagus, and you can see, if you're just looking from the outside and looking at the superficial layer, you may see this abnormal tissue and want to remove it, but you may not see anything growing deeper or in the lymph nodes. So while this is the best way to tell if you have it, to see the degree of it, sometimes you need the ultrasound technology as well. And so this is what a normal esophagus looks like. See this round, tubular type structure. This is my actual scope and the ultrasound machine on the inside. And we can see the full thickness of the esophagus and look for any abnormalities. So over here we have a nodule. This is nice, thin. You have 5 different layers we look at. And you can see the alternating light, dark, light, dark. This right here is a nodule. And before I remove this nodule, I'll take a look and see if it's growing deep. So this is dark line is the muscular layer of the esophagus. On the outside, if we go through that, first 2 things. 1, how deep is this nodule? And 2, if I try to remove this, will I make a hole in your esophagus, a perforation? That would also be dangerous and require urgent surgery. So I want to make sure that we select the right patient and right nodule. So this nodule here looks pretty superficial. This muscular layer is not involved, so I can go ahead and snip this thing off and get rid of that abnormal tissue before it becomes cancerous. EMR, there's 2 ways to do it. This is also how we kind of remove polyps. We'll inject some fluid under the abnormal tissue, lift it away from the muscle, and then we can cut it off with what's called a snare. We use electricity current to kind of burn right through it. And then there's something called band ligation. So it's a little hard to see, but this is abnormal tissue right here. And we'll actually suction this up into the scope and put a rubber band around it below that. So this is all normal tissue, and basically we'll take a little snare, a little round loop of metal, and we can cut through this, removing all this abnormal tissue, but leaving all the good tissue behind. And this is an example. So over here is a cutout portion of a nodule. There used to be a nodule here, and now it's been removed. And again, all endoscopic, minimally invasive, very safe. There is some risk for bleeding like any endoscopy, but it's on the low side. And then this is the catheter we use for the burning. It comes in all, again, since Barrett's comes in all shapes and sizes, we have all different types of catheters that we use. This is a full 360 balloon where we can burn the whole tubular 360 circumference of the esophagus. And then we have very focal catheters, just small little bits we have to burn. And we don't want to burn good tissue because it does cause some pain. So we'll just do very finesse small areas of burning to eliminate the Barrett's. And you can see over here, this catheter was used to create a nice little area of burn. So we get a nice focal area, kill the bad tissue, leave the good stuff behind. And those are the most recent updates in the world of GERD and Barrett's esophagus.